When people hear the name Canada, I don't know what images come to their mind. Maybe extreme temperatures, minus 30 and 40 below zero, extreme cold weather warnings, and then sometimes we have snow. So one wonders why so many people want to go down to the Caribbean, eh? So 2.5 million visits to Caribbean occur annually. I've also listed the top 10 warmer travel destinations that Canadians visit. The USA, Mexico, Cuba, Dominican Republic, and Jamaica. This is from the 2012 Stats Canada data. Currently, all testing for chikungunya is done at the National Microbiology Laboratory, NML, in Winnipeg, Canada. This figure here shows you what typically we've seen with our number of chikungunya requests over the years. So typically we see between 50 and 200 requests per year, and this includes acute and convalescent samples. However, in the year 2014, we just received over 1,900 requests for chikungunya serology. As of this year, 2 months into the year 2015, we've received 781 requests for chikungunya serology and/or PCR. Due to the limited number of requests we've received over the past years, we've been able to get away, for lack of better terms, with a lower capacity testing, lower volume testing. We've used the hemagglutination inhibition assay, HI. We use an in-house produced suckling mouse brain antigen, and we also combine this sometimes with a commercial IFA from Euroimmune. However, as of February last year, we switched to the CDC-based methodology for the IgM ELISA. We use a tissue culture-derived antigen that is produced in-house at NML. Our testing algorithm follows a pattern that all samples that test IgM equivocal will then be tested by RealTime PCR. All positive samples are further tested by the PRNT, that's the plaque reduction neutralization assay, and RealTime PCR. The reason that we have chosen this two-pronged approach to testing samples for confirmation is that we often do not receive a date of onset. We receive limited clinical information, and so we're concerned about missing patients. Just to briefly go over our real-time assay, it is based on two primer probe sets. One is directed at the non-structural polyprotein region and another at the envelope region. For a sample to be considered PCR positive, it must produce a CT value of less than 38 with both primer probe sets. As part of our assay development and QC, we've participated in 2 external panels, one from the European Network for Diagnostics of Imported Viral Diseases, and the second with the FDA, who are working on the chikungunya working stock reagent. Typically, we see between 15 and 20 positive samples a year. So for the year 2014, we had a significant increase in the number of samples and a significant number that we confirmed as positive. We confirmed 427 cases of chikungunya, and our confirmatory test, our gold standard, is that a sample must be PCR positive and or print positive. We also have 127 probable cases yet to be confirmed. And this data is as of February the 20th of this year. We still have a backlog of samples that we're dealing with. What was interesting to us is that up from our confirmed cases, when we looked at viremia, is that 20% of our returning Canadians are viremic. We're also looking at verifying the number of, we have 64 samples that fit in the confirmed probable category that were PCR equivocal. They did not meet this cutoff with both primer probe sets. As time permits, these samples will be subjected to conventional and nested PCR so we can get a firm grip on the total number of Canadians coming back that are viremic. This figure just shows you that from our 2 most populous provinces, Ontario and Quebec, that is where the majority of our samples are coming from, which is one of the reasons that one of the projects that we're working on is trying to have a technology transfer so that the 2 most populous donors, if you will, of samples take over the testing. So one of the things we're doing is validation of the Euroimmune IgM Chikungunya ELISA. We use 2 different lots of ELISA lot kits, and this test was performed over several months. For specificity testing, we looked at 60 samples. that were tested IgM negative on the in-house ELISA. 36 of these samples have documented travel history. And looking at cross-reactivity and looking at what we just had in our collection, one was positive for Ross River IgM antibodies, one for West Nile, and 10 were positive for dengue virus antibodies. What we found was that 58 of these samples that tested negative on the in-house assay also produced negative results with the Euroimmune ELISA. However, 2 samples generated equivocal results for the IgM on the Euroimmune. This gives us a specificity of 97%. This is a little bit more complicated to explain. This is the sensitivity testing, and again, we looked at 2 different lots. We had 100 samples that tested in-house ELISA IgM positive, and of these, 71 had documented travel history. We looked at sensitivity in 2 different ways. So if we look at samples that are confirmed by print positive alone, there's 74 samples that were confirmed IgM positive and print positive. We see 100% concordance between the Euroimmune and our in-house assay. If we look at it a different way, that of these 100 samples, these samples were confirmed by print, real-time PCR, or HI, so one of the 3 or a combination. What we found was that 4 of the samples that were print negative but were PCR positive generated equivocal results with the Euroimmune. 1 sample that was print positive had not been tested by PCR, generated equivocal IgM results, and 2 samples that were print negative and PCR positive generated negative IgM results on the Euroimmune assay. And part of this has to do with collection dates. Has the patient had enough time to generate antibodies, IgM antibodies? So looking at this method of our testing, we are saying that the sensitivity of the assay is 93%. At this point, we will be recommending to our client laboratories in Canada that they initiate testing for the Euroimmune ELISA. At NML, we will be switching over to the Euroimmune as an initiative. One of the other, as an aside, problems that we do need to address with our frontline clinicians is that we also have limited travel history. So this pie graph just shows you that we only have 30% of our cases we are getting documented travel history. You can see that not all our cases have originated from the Caribbean, but 93% are from the Americas. Looking at the Canadian perspective, there's just a few points to bring out that Canadian travelers need to be aware when they're traveling, not just to the Caribbean, but anywhere else, that is, if there is a risk for arboviral infection, that they need to carry proper protection and to actually use it. We do not have Aedes aegypti in 80 species, specifically Aedes albopictus in Canada, but we are looking at modeling research for the possibility that albopictus could become established in Canada. As I've already mentioned, we are looking at tech transfer between the provincial labs to increase their capacity. And lastly, this goes back to testing samples for viremia. Is there any possibility of chikungunya being transferred by blood? And is this an issue? And that's one of the reasons why we're examining that further. With that said, I'd like to just show you this picture of the National Microbiological Laboratory. We're a small lab. Dr. Durbin could not be here, but he is our Director of Viral Zoonosis and Special Pathogens. Dr. Lindsay, our Chief Acting Viral Zoonosis. Christina, Kai, Maya, and myself. And I just feel after showing you that picture of snow that I have to show you something positive about Canada. Thank you.